Hello and welcome to our next discussion for your Harrisburg Area Community College Blended Learning EMS program. My name is James Weber, and today's discussion is in regards to EMS documentation. EMS documentation continues to be an area of EMS where we continue to just simply do really poorly. And it's something in which can really have some significant ramifications on our careers, on our organizations, and on our communities as a whole. The responsibilities of an EMT go well beyond just traditional assessment, management, and transport of a patient to the hospital. We've also got to be able to prepare a patient care report to document what was completed in the set pre-hospital setting, as well as make sure it's reviewed at a later time. Now, why do we document? There's lots of different reasons why we actually conduct documentation. First, medical uses. Of course, we've got to make sure that we're helping to ensure the continuity of care once patients delivered to the hospital to the emergency department. And that documentation kind of butts up against the documentation that the hospital does to ensure they have complete documentation from the point in which the person became sick to the point in which they were discharged from the hospital. Legal uses. It's not the most important reason, but one of the more important reasons why we document is so that there is a record of the case, record of the event, so that you have something to support what you did in the field when it comes to legal proceedings in the future. Education and resource, a lot of documentation is actually used as aggregate data as they begin to do EMS-based research to determine whether EMS actually has the positive influence on our communities and outcomes that we believe that it does. Administrative uses, it becomes part of the permanent medical and billing records maintained at the hospital for the patient, and it will be used in preparing bills and subsequent records for insurance companies as well. Quality improvement, right? This is your organization's opportunity to review documentation, any documentation that you do, and it's really going to be part of organization levels as well as medical command physicians determining whether the care in which you provided was adequate, and they can do so by reviewing your documentation. PCR. Any information that's on the PCR should give a clear and accurate picture of what occurred during the pre-hospital environment. The major rules to consider if it wasn't written down and it wasn't done. And if it wasn't done, of course, don't write it down. We're not looking to make anything up, but we are looking for a thorough and reasonable account of what occurred during that patient contact. General completion guidelines. Fill out the form in its entirety. Make sure every box is complete. Make sure every space is complete. There should be no blanks. Of course, make sure that when you spell, we're spelling correctly. We're using proper spelling and sentence structure and only approved medical abbreviations. Should you work for an organization that's still using paper reports, which doesn't really happen much in the state of Pennsylvania, but there are still states and actually major cities that are still using paper reports. Make sure you're using black ink. Make sure you correct any errors in an accepted manner. Make sure you're very clear on what your spelling is before you actually document it. And make sure you read it over once before you file it. Computer-based reports, use spell check, right? Make sure you are checking for any automatic drop-down boxes, and of course, read it before you file it. Just be more careful with spell check. Spell check can be kind of challenging. These are just some examples of ones I was able to kind of pop into my head. Patient is warm, oink, and dry. Of course, the word should be pink. Now, would autocorrect catch that? They wouldn't, because oink is a word. It doesn't look to see if that word is appropriate in the context of the sentence. It just wants to make sure that it's spelled correctly. Contacted the coroner, right? A lot of people actually spell their words phonetically, which is incorrect, especially in the English language. But this is an example of contacted the coroner should actually be spelled differently. Coroner, especially in Pennsylvania, is somebody who comes and picks up bodies in the field and does investigations and does autopsies. That is definitely not the same as coroner is in the corner of a table or corner of a chair. Patient has toe lacerations, right? Just an inversion of two letters for the word TWO. Just inverted two letters. and it still wouldn't have been caught by spell check as well. So things to consider in regards to spell check. Essential components of documentation: chief complaint, history of present illness, sample history, initial exam findings, any physical exam findings, vital signs interventions, and any response to interventions. Some methods for charting, right? These are just some examples of acronyms that are commonly used for charting. There's a SOAP note and a chart note. A SOAP note is as simple as subjective, objective, assessments, plan, and evaluation, versus chart, which is chief complaint, history, assessment, treatments, as well as any treatments that were documented, as well as what occurred during and at the end of the transport. All things in which you're going to consider. That tends to function in more of a timeline capacity. Some tips to consider: scene size up. When you talk about mechanism of injury, tell a really good story in regards to any injury mechanism for trauma patients. For example, information about things like the position of the patient, the approximate speed of the vehicle, location damage to the car, any airbags that deployed, or if it's a fall, maybe the distance of a fall, what kind of surface that they fell on, and a helmet or no helmet. For example, I picked up a gentleman who fell off a roof a number of years ago, and he was still alive after falling 9 stories. And it sounds like that's something you generally wouldn't survive, but he fell 9 stories into a pretty soft mud pit. Now, was he really, really, really significantly injured? Of course he was. But he survived simply because of the surface that he landed on. So it's important to document that when it's appropriate. And of course, helmet or no helmet allows for a little bit of additional information in the mechanism as well. Also, document any clues pertinent to patient condition, things like environmental changes, pill bottles, alcohol containers, things like that. Sample history, right? We've got to document sample history. This is something in which we, as EMS providers, have tended to not do well later on in our careers. When we document, we want to document a sample history. And we want to break it down in that sample history acronym, since that is such a common way to report off that information. So, of course, again, signs and symptoms. You want to put anything out in regards to signs and symptoms, HPI, OPQRST, allergies, medications, past medical history, last oral intakes, and events leading up to the problem. Get that sample history out into the documentation. When we talk about medications, you want to document pretty broadly any medications in which you have given. Now, when we talk about medications, it's just not appropriate to say, well, I gave oral glucose, right? Or I gave glucose, which is commonly how that's described. Instead, you want to say, I gave oral glucose, which would be the name of the medication on the route. I gave a dose of 15 grams, and I gave it at 15-25 hours. And of course, the patient responds. Patient became more aware of their surroundings and started to respond to questions more appropriately. That makes sense. Anytime you provide a medication, you want to document not just the medicine, but how you gave it, when you gave it, and what the response was. Splinting or spinal immobilization. It's important not just that we do PMS before and after every application, but that we chart PMS before and after every location or every application of a splint. Could you imagine a scenario where you take a patient in the hospital that has a splint on, and there's no PMS at the end of the splinting, and you don't check, and they get to the hospital and spend a lengthy period of time without pulses to that extremity. It's pretty important from a legal protection perspective that you make sure that you document the fact that you did that post-splinting PMS, and you document the fact that it happened. Of course, ongoing reassessments, right? Anytime you're not doing anything with a patient, it's important that you reassess them. When we reassess, we've got to reassess every 5 minutes for unstable patients or 15 minutes for stable patients. Document any response to any interventions, any changes in status. Most organizations that I've ever worked for, if I don't document vital signs every 5 minutes for unstable patients or 15 minutes for stable patients, the chart ends up back in my lab again and I need to edit it. It's important that you start today documenting vital signs every 5 minutes for unstable patients and 15 minutes for stable patients, as well as any response to interventions and changes in status. This is an example of an actual run form that I was able to pull out for discussion. So let's talk about it. Upon our arrival, found patient in bed with first responders complaining of breathing difficulty. Patient physician saw her yesterday, had cold times 2 weeks. Physician said lungs were congested, nauseated, no vomiting. Listened to lungs equal but noisy. Patient initially put on 4 liters of needed non-breather, complained, so we used 24% Venturi. Allergic codeine, Dr. Bitlet. Patient diabetic due for insulin 8 o'clock. Meds insulin. Couple of things. Upon our arrival, patient was found in bed with first responders, complaining of breathing difficulty. Who was having breathing difficulty? Was it the patient? Was it the first responders? And specifically, why were the first responders in bed with the patient? So let's talk about those SOAP notes we discussed before. It really is a system for documentation. So let's talk about it. SOAP system: subjective, objective, assessment, and plan. Now, chart is a little different. It's basically chief complaint. So what is the patient's chief complaint? History, any findings during the assessment, any treatments, as well as transport. Let's break down SOAP first. Subjective, right? It's the chief complaint, history of present illness, past medical history. History of present illness, of course, breaks down into some of that OPQRST as well. That's part of the subjective history. And that breaks down as well. You guys know what that means. Now, past medical history. Of course, that's medications, allergies, illnesses, doctors, surgery, allergies, medications, past medical history, last oral intake, and events leading up to the illness. It's important that this is really the crux of the information that we gather during the call and subsequently document as well. Because could you imagine if we don't gather that and it turns out the patient's allergic to something that the hospital gives them? That's kind of problematic. We need to capture that information as quickly as we can. Objective assessment, right? It's everything from patient appearance to position to surroundings, head, eyes, ear, nose, throat, neck, chest, abdomen, pelvis, extremities. These are objective observations about the patient. So again, subjective is things we determine and process. Objective, that is just what we observe. Some other examples of objective assessments, things like patient appearance, position, surroundings for the neck, where you see or don't see any issues with jugular vein, specifically jugular vein distension. Chest, lung sounds, kind of important, right? Pedal edema, oxygen saturation. Altered mental status, patient appearance, position, surroundings. Mental status, alert, verbal, painful, unresponsive. Are they oriented to what's going on? Any memory lapses they might have had, or did they have a period of loss of consciousness? You're going to put that into the objective portion, that stuff in which you can determine through your assessments. Pupils, trauma exam, including movement of extremities. If anybody's checking blood glucoses as well as oxygen saturations, and EKG, provided it's within your scope of practice. Narrative comments, right? Let's talk about pertinent negatives. Pertinent negatives is simply what is going on with your patient and what isn't going on with your patient. A pertinent negative is something that isn't happening with the patient, but is pertinent that you ask. Good example. If a patient is complaining of chest pain, it's important that you document the presence or the absence of difficulty breathing, because do chest pain and difficulty breathing commonly go together? They certainly do, and a lot of the times if a patient's having chest pain but no difficulty breathing, that can either negate or at least lead clinicians in a different direction in regards to what's actually happening with the patient. What is their working differential diagnosis? Another example, if a patient has a blow to the head, document whether the patient has lost consciousness, right? It's important that you would want to document that pertinent negative. So while it may not be one of their chief complaints, right? They don't have a chief complaint of loss of consciousness, but it's pertinent to know if they got hit in the head, whether they had a corresponding loss of consciousness as well. Some other examples of some real principles of narratives. First, describe but don't conclude. A well-known, this example of a narrative, right? It's a great narrative that was put in by a doctor in the late 1970s. Unfortunately, he lost a pretty significant malpractice suit during that period of time. And this is an example of why. A well-known, unshaven, unkempt, foul-smelling, slightly cyanotic, 62-year-old alcoholic gentleman was carried to an emergency room with 3 million lice, all screaming, "Please save our host," which is so wrong to write in a narrative. Hilarious to some extent, but so wrong to write into a narrative because it's a conclusion, right? You have concluded that this is what's going on with the patient. We run into this a lot with alcohol, okay, in the field, where we document patient was drunk. Well, okay, but we don't carry anything to conclude the patient's drunk. We don't carry a blood alcohol breathalyzer. We don't carry the ability to do lab diagnostics in the back of an ambulance. So our documentation can't say drunk, alcoholic, intoxicated. It really should say patient has a smell of odor of alcohol on their breath. Right? Again, it's all about descriptions. Slurred speech, frequent mood swings between happy and combative, inability to walk without any sort of assistance, and odor of an alcoholic beverage on their breath. Is there any need to say that they're drunk? No. We can say that they're drunk without saying that they're drunk. Use descriptive terms to describe their actions and allow the reader to come to the conclusion. The moment which you put a concluding factor about what you believe is occurring, you're going to have to stand behind that in a court of law, and that's a terrible idea. Record important observations about the scene, right? Here's an example. It's a suicide note actually found next to a patient. Patient who had committed suicide. I can't live without my Polly. I'm going to kill myself. Respectfully, Sheila. That's an example of a note in which guides people into what occurred. Could you imagine if somebody was found with life-ending injuries, fatal injuries, but they didn't have a suicide note? Maybe there might be an investigation, possibly a murder investigation. It certainly makes a difference as to what kind of condition the patient was in before their injuries were there if you find these types of notes at the scene. Sometimes the notes are good. I treated a young lady who attempted to kill herself by jumping in front of a train. And she actually put a note on her chest that said, please do not resuscitate. Right? Actually misspelled the word resuscitate, but that's a whole nother discussion. Just because there's a note there doesn't mean we need to follow it, right? Obviously, we did attempt a resuscitation in that circumstance. So our point is, while this documentation is super important to document, it's not necessarily something you have to follow. Standard abbreviations. It's important that we follow standard abbreviations. Abbreviations can be misconstrued. Right? We don't want to put ourselves in a position where the reader isn't entirely sure as to what we mean because we chose a non-standard abbreviation. Ideally, most organizations really should be giving you, when you work at that organization, a list of what is a standard abbreviation. Although we're finding EMS has been very slow in adopting standardized abbreviations in healthcare. Just some examples of ones in which you want to avoid because they're not standard. Of course, things like circling the drain for CTD, HIB, GIA, had it before, got it again, and of course FTD for fixing the die. These are just not standard abbreviations. They're not appropriate in healthcare. And these kinds of things, while interesting, to some extent amusing, they're just not standard abbreviations that we want to utilize in the clinical space. Including any changes in the patient's condition after treatment while en route. For example, you gave a patient a tube of oral glucose, they became lucid and thanked you profusely. Great. That's something you want to document in your actual patient care report. That exact sentence, because it demonstrates the fact that your care was effective. Identify any sources of information when it's not the patient, right? If you're going to say a patient used cocaine for 2 years, you need to document how you got that information. You can't just conclude that the patient has used cocaine for the past 2 years. You need to actually identify why you're saying that information, who gave it to you. Also, of course, you got to learn from other people's experience as well. So a little bit of evaluate the following narratives and describe how they could be improved. Note, a little bit of information has been typed for ease of reading, but these are actual forms. This is actual information. The handwriting was atrocious in some of the forms. That's the reason why we typed it. But here's an example, right? Patient has not been feeling well times 1 day. 4 a.m., patient started vomiting, uncontrolled bowels, aching in both arms and shoulders, temp of 39.1. Patient's taken Dactyl at 0116, again at 4:30. No meds, no doctor, no allergies. It's for a 20-year-old female. And the vital signs as recorded. Strengths. First, you'll notice 2 sets of vital signs, right? That's pretty darn important because we at least have to get 2 sets of vital signs in every patient. I don't care if you're working in a city system. I don't care about your circumstances as it relates to the amount of time you have the patient. We've really got to get at least 2 sets of vital signs. Now, if you've got this patient for longer than 30 minutes, an hour, hour and a half, 2 hours, you're doing long-distance transports, there really should be multiple vital signs charted. But 1 set of vital signs every 15 minutes with 2 vital sign minimum for every patient contact. Some ways to disorganize, some ways to improve. Of course, first, it's super disorganized. It's skimpy. What was the actual chief complaint? And of course, we've got to recognize and treat shock when the patient has it. Let's go back to the patient's vital signs, right? We've got a really terribly dropping, failing blood pressure kind of going on here. And we've just not done a very good job at managing that. And let's go back to, of course, what's the primary chief complaint? Not feeling well? That's not an appropriate chief complaint. We really need to dial in a little bit further on that chief complaint to determine what the true complaint is. It may be as simple as vomiting and uncontrollable bowels. But if that's the case, that's what's got to be reported as the chief complaint. It could be something entirely different. It's just disorganized and poorly put out there. Here's one that's a little bit better, right? Right compound open femur fracture, lacerations on the inner right thigh, right ankle, right toes, right little toe underneath, abrasions. Both elbows, 4 burn marks, 1.5 diameter in the thoracic lumbar region of the back. Femur fracture with bone coming out of the medial aspect, approximately 3 inches above the knee. Open wound, approximately 3 inches long. Lateral aspect, approximately 2 inches above the knee. 1 open wound with a great deal of bleeding from the medial aspect of the wound. Contusions and lacerations to the tib fib area of the right leg. Patient has good motor function of the toes on the right leg and good distal pulse. Patient's drowsy and difficult time getting a radial pulse. No guarding in the abdomen. Breath sounds are good. No known allergies, no known medications. Patient took off their helmet and jacket prior to arrival. Strengths. Super detailed description of the injuries. And they identified and treated shock. This is actually a paramedic level ambulance, so you'll notice up at the top right, they did things like providing fluid and drawing bloods, and that's really evidence of the fact that that shock that they had was treated. Now, the one thing in which they didn't do, they really put no information on there on how the patient was actually injured. Now, going back to the chart, it's not hard, based off of that last sentence, patient took off helmet and jacket prior to arrival, to determine maybe it's a motorcycle accident. Maybe. Now, of course, there's femur fractures, which would be another indication as they came off the bicycle and struck their leg on the handlebars that might be a motorcycle accident. But we really don't actually have anything clarifying in the paperwork to suggest that that's absolutely what it is. Let's go to our third example. 68-year-old male found lying face down on the bedroom floor and had vomited. Patient is responsive to verbal stimuli, could answer questions with single words, but just couldn't tell us what happened or speak understandably. Patient was able to move all extremities oriented to person only with a large contusion to the left forehead, small abrasion to the right forehead, and upper bridge of the nose. Pupils constricted. Wife reports history of stomach problems, but was very upset, unable to give a good history. Some strengths. Great description of the abnormal mental status. Good explanation for the lack of history as well. It's actually a decent set of documentation based off of what they were presented with, and it really did a good job highlighting towards the end, why don't you know more about this patient? Patient's not able to put information out there, only single words, only responding to verbal stimuli. Wife's not able to put a lot of information out there as well. So here's what we saw. Good. That's a decent, at least initial contact sentence or a paragraph, which is a great thing. Example number 4. Arrived to find alert and oriented, times 3, 28-year-old female with substernal pain that started approximately 4 hours ago and has been constant. Pain radiated into the back, skin warm, pink, and dry. Pain felt as something heavy. Lungs are clear and equal bilaterally. Had a stress test earlier today, unknown results. Transported 10 liters per minute, non-breather mask in Fowler's position, with a little bit of information in regards to history. It's a set of vital signs as well. Some strengths. Great job in regards to history of present illness and 2 completes of vital signs. You really can't beat it. So that's just some examples of kind of some narratives and beginning of some of HPIs that maybe we could do better, or maybe weren't all that terribly bad. But it's important to, first, document heavy, document as much information as you absolutely possibly can. Make sure you have a system for completing the PCR. When it comes to documentation, we are going to send you some samples from our instructor base on PCRs in which they have put together. It's important in that documentation that you see kind of what other people do and utilize that SOAP and chart note examples and begin to develop your own system for completing PCRs. It's also pretty important that somebody else checks the form as well. I tell you something, in the 16, 17, 18 years I've been doing EMS, plenty of times I've looked at my partner, whether they were at the same level of me or above the level of me or below the level of me, had them look at my form or my documentation and say, did I miss anything? Did I capture everything I needed to capture? Sometimes they've made suggestions, other times it's been good, but it's important to get another set of eyes on that document. Also, be very mindful of spelling and punctuation pitfalls. Make sure you're utilizing whatever spell checks you can. And of course, use non-transport forms whenever appropriate. Should you have any questions, reach out and talk to your program coordinator. But other than that, this is the conclusion of our documentation discussion. At this point, I appreciate your time. I appreciate your energy and the opportunity to work with you in regards to the blended learning programs here at Harrisburg Area Community College. And we look forward to seeing you at our next lesson.